thank you so much for the kind introduction, and I really appreciate the planning committee, Scott and Brenda, really inviting me here and getting a chance to be with you all. I think what I've seen, what you're all doing is very commendable. So I want you all to give yourselves a round of applause for the fact that you're all in this room together and that you're here trying to make the lives better for women and children and babies in the state of Tennessee. So what you guys have here is quite special, and I think that you should be empowered to have a collective voice to really fight for and work for mothers and babies in the state of Tennessee. And you guys are doing a great job and testimony to the work that's being done at the state level. So you should be all congratulated about that. So I'll go into artificial intelligence, and there's two parts to me being here. The first, I'm just going to highlight what artificial intelligence is. Many people are confused by that. A second component of me being here is actually providing a workshop, and I'll do what Scott just highlighted. I'll teach you all how to use some publicly available free large language models and use them in a way that can actually help you in your daily life or even in quality improvement projects, to teach you how to prompt a little bit. But what I'm going to do here now is really to make you realize that artificial intelligence is actually here. It's not something of the future. It is here in a bigger way than maybe you realize. I have some disclosures to make. I will bring up company and product names. I'm not endorsing them. I have no financial relationship with them. I bring them up as examples. I've been a paid site investigator for aerosolized surfactant trial. I'm part of NeoMind AI, a co-founder of that group, which is a group of neonatologists, data scientists, clinical informaticists that are working together to apply AI in our healthcare space safely, effectively, and ethically, and as unbiased as possible. And I invite you to join us. So we're on a journey of collaboration and learning along the way, because this is a new technology. And then also I've been paid to travel around and talk and present at different conferences for the AAP as part of the section of neonatal perinatal medicine. So AI is here today. There's a lot of tools, and I'm going to highlight a lot of them, and current uses of AI, and there's a lot of them, and then how you can actually learn yourself. So first, I want to talk a little bit about myself. Scott kindly introduced me. I grew up in a town of 100 in Montana, in a small ranching valley. Anybody here grow up in a town smaller than me? Ooh, what do you got? Less than 100? Okay, very nice. Very few times do I ever have anybody who grew up in a town smaller than me. 16. So 14 was in my kindergarten through 8th grade, 2-room schoolhouse. We had 14 kids. So 18, that's pretty good. So first of all, I still use a phone like this to call my son in Washington, D.C. When I want to communicate with my mother who lives in Pensacola, Florida, I pull out a piece of paper and a pencil, create a letter, and send it through the U.S. Postal Service. When I want to do calculations, I pull out a pencil and a piece of paper. When I want to detect congenital heart disease, I use a stethoscope in my hands. Do you guys do this? Or am I just that way in Colorado? Well, of course, I don't do that, and neither do you. It is 2025. It's not 1989. We use available technology to improve the care that we provide to our patients. And in this case, we're using cardiac MRI, ultrasound, vital sign monitoring to help us detect congenital heart disease. In order to communicate with my family, I use a cell phone and talk on that. I send text on social media. It also has a calculator. So we use technology in every day of our lives. And AI is going to be a technology that we are using today and going forward. So our NICUs are supported by huge amounts of technology, with monitors, with imaging devices, with ECMO, with CRRT, with the isolettes, ventilators. We use technology every day. And I'm here to ask you, do you think that AI will be a technology that we use today and going forward? And the answer is yes, because it's already here. And that's what I'll talk with you about today. So why am I here talking with you about AI? Am I a world's expert in artificial intelligence? No. If you knew me 5 years ago, you would say, Jim Barry and artificial intelligence, there is no way he knows anything about it, and there's no way that he's going to be talking with us about it. And that indeed was true 5 years ago. If you knew me, you knew that I would adopt technology. I'm an early and late majority adopter of technology. Because as a medical director, I think that things have to be proven safe and effective before they become widely adopted in practice. So I'm not on the early innovative side or the early adopter side, because I think we really first have to do no harm with our technologies. So healthcare is a lot like me, still using fax machines. So we're the only industry that still uses fax machines to communicate with one another. Vital information that we're trying to pass on to our community providers, our families, by fax machine. So the world of healthcare looks a lot like me. But one thing I've learned about myself in the last 25 years is that I like to fix things. And I like to work on teams, communication, teamwork, improve systems and processes so outcomes for our patients and families are better. And it really comes from the fact that I've been a medical director for 17 years and a service line director now for about 5 years, over 15 hospitals and newborn care services. So I like to fix things, and it took me like 25 years to realize that about myself, that that's really what gets me up in the morning and what gets me interested. My purpose for the next 10, 15 years in specific is to improve pediatric healthcare. And I've really been focused on neonatal healthcare. And so I put this slide together to say that I've been involved in working on reducing preterm birth rates in the state of Colorado. We had a task force that came together now over a decade ago. And on the far right shows all the different individuals that were involved, coming from various backgrounds, different programs around the country. And that's what I've seen you all do, is pulling people together to work for a common cause, and I think that we need to continue to foster that. I'm always on the lookout for ways to improve care. And so in 2019 to 2020, I started hearing healthcare leaders talk about artificial intelligence. And they were telling me how artificial intelligence was going to solve our healthcare problems, improve the care that we're going to provide to our patients. And I would ask them to define that, and they really couldn't. But I heard it enough times that finally I'm like, man, all I could think about was artificial intelligence. You guys know iRobot and Will Smith, that movie. All I could think about was Sonny saving the world from all the evil robots. I'm thinking, that probably isn't the AI that healthcare leaders are trying to tell me about. So back in 2020, 2021, I decided I'm going to take a deep dive in trying to understand what artificial intelligence is. And to be honest with you, I was very skeptical that artificial intelligence was going to solve any of our problems. I took a course, American Board of AI in Medicine. So if any of you are thinking about taking kind of a first step into the fundamentals of AI, this is a good course to take. It costs a little bit of money. I learned some good fundamentals, but I also learned that there's a community network around the country and internationally that's working together and are thought leaders in AI and healthcare. So I now meet with this group multiple times per week. I'm involved in thinking about medical education and other things with them. So for me, it opened my eyes that there's a community of really bright thought leaders that are working together already. Here's some of the resources that I use: books, websites, online courses, and I think that you guys have these slides. There's too many things for me to go through. There's now 2 medical journals that have AI associated with them, New England Journal of Medicine and JAMA. And then also on LinkedIn is where I follow a lot of people who are really smart and post really insightful thoughts about AI and healthcare. So if you want to follow me and others, LinkedIn's a good place to go for that. So after I started teaching myself and learning from others, I really thought that AI was way off in the distance. And then this happened. ChatGPT blew up on the scene in November of 2022. Really took the world by storm. And really, from that moment on, really changed my approach to AI. It changed society's approach to AI. And this is the Gartner hype cycle that shows what happens when a new technology is developed. There's a lot of hype surrounding it, that this technology is going to save the world, do all these things. Kind of what you've heard about ChatGPT and other things. It's now sliding down into the trough of disillusionment, where we're realizing that it can't do everything that all its developers told us that it could. But over time, it'll swing up to the plateau of productivity where we understand the advantages and disadvantages of these technologies. ChatGPT, when it arrived on the scene, it took 5 days to reach 1 million online users. It took 2 months to reach 100 million online users, much faster than any other online media platform before it. So it really took the world by storm. When I go around the country and talk with people about artificial intelligence, there's usually a wide spectrum of what people think about artificial intelligence in healthcare. Some fear that it's going to destroy care as we know it. Others are over-exuberant and feel like it's going to solve all of our problems. So I want you all to raise your hand. Who fears AI and is concerned that AI will disrupt healthcare and make it worse today than it is, or worse tomorrow than it is today? So I want to see you raise your hand. Who thinks AI is going to cause problems? All right, very good. Who thinks it's going to solve all of our problems? Well, that's good because I'm right there with you. So I would say back in 2022, when I would ask these questions, most people would raise their hand and say, I fear it, it's evil, it's harmful, we shouldn't be using it. I would say in the last couple of years that's changed, and I'm getting more people to say, maybe there is something to artificial intelligence. And so I'm going to ask you right now to do what I've done over the past couple years. I'm not a data scientist. I'm not a computer scientist. I'm probably not very smart. Many of you are much smarter than me. But what I decided, I was going to open my mind to the possibility of artificial intelligence being a positive thing. So I had to erase these thoughts from my mind. AI can't, AI won't, AI shouldn't, AI couldn't. So I want you to remove those thoughts from your mind. And I'm going to go forward here. And the next part of my talk is to show you where AI is already kind of being involved in healthcare. We have entered the age of AI in our society. We've now moved from information age, industrial age, computer age. We're now in the age of AI. So this slide is intended to look really busy because it's representing the applications of artificial intelligence in healthcare. Broad categories being research and development, operational efficiency, patient care and management, diagnostic and imaging, predictive analytics, personalized medicine. It's going to be and will be touching many aspects of healthcare. The FDA has approved over 1,000 AI-enabled devices in the United States. That's an increase of about 92% over the last year and a half. The vast majority of these AI-enabled devices are in the field of radiology and cardiovascular devices. If you look at pediatrics, which is my home and the home to many of you, we're being left behind. Only about 1% to 3% of these devices are applied in pediatrics. And many of you are probably like me and think FDA approval is a really rigorous, stringent process, that these devices must go through a really scrutinized process before they get FDA approval. It's not as stringent of a process as I would have believed. So this is a publication that really looked at some of the devices and potential for bias that exists within them. Less than 1% of the models provide any socioeconomic data on the studied populations. Only about 2/3 report on anything about sample size in the studies. Only 21% report potential risks to the users of these devices. Only 2% provide documentation on their safety and effectiveness. And for us in pediatrics, only about 19% of the device manufacturers even describe patient population of pediatrics being studied for the devices. So just because it has FDA approval doesn't mean it's ready for prime time in our clinical space and really needs further evaluation and scrutiny. So the way these devices are set up, there's a particular potential bias, especially for pediatric population. And these AI-enabled devices, you can get paid to use them. There's now CPT codes and NTAP codes that can be used to use these devices, and you get paid for them. This figure illustrates from 2018 to 2023, there was one CPT code in 2018. There's now 16 CPT codes as of March 2023. And you can see the top figure, what it highlights is the increased number of claims per month using these codes. Most of it's in adult diseases such as cardiovascular disease and retinopathy. but they're starting to be used. So if you have a device, you can get paid to use the device. Guess what's going to happen? The device is going to get used. This is a slide that's supposed to be really busy, and what it highlights is different companies that are involved in applying generative AI in the healthcare space. And this is really from June of 2023, and if I were to show you exactly today, it's probably double the amount of companies. But the areas that they're applying generative AI in healthcare is pretty wide. Drug discovery, clinical trials, personalized medicine, and genomics. And I can't read because my eyes are old. Care navigation, surgical robotics, note-taking, revenue cycle management, prior authorization, recruiting, and medical coding. So really across the gamut of healthcare, these companies are developing generative AI applications. This past fall, 4 individuals received the Nobel Prize for work that they've done that's associated with artificial intelligence. Geoffrey Hinton and John Hopfield won the Nobel Prize in Physics for the work that they had done creating neural networks, which really are the foundation of the AI revolution that exists today. Demis Hassabis and John Jumper won the Nobel Prize in Chemistry for their work on protein structure prediction. They helped create something called AlphaFold 3, which takes amino acid sequences, predicts protein structure and function based on those amino acid sequences. Something that scientists had worked on for 3 decades now can be done in the matter of minutes with this AlphaFold 3 program. The pharmaceutical industry has certainly taken notice of the application of AI. In 2022, they spent about $1 billion. It's estimated that they'll spend $22 billion on AI applied to the pharmaceutical industry in 2027. Reason this is they're able to use artificial intelligence to decrease the time it takes for a drug ideation, creation, study, production, marketing from 10 years to 5 years. On the far left of this screen, you'll see the different pharmaceutical company names, the biotech provider that they're working with. Most of them are working on small molecule drug design and clinical trials. Speaking of clinical trials, there's something called digital twins. How many of you guys have heard of the term digital twin? I know one person has for sure. We talked about it this morning at breakfast. So digital twin is something where computers model aspects of our physiology when we're talking about like clinical trials. But basically it can take data and model a single cell's physiology. Also an organ like the heart or a patient. And it creates a digital twin of the cell of the organ of the patient and is able to really replicate that physiology. And it's being used in clinical trials. And the reason that is because about 80% of clinical trials are delayed due to patient enrollment. Only about 10% of compounds that make it to clinical trials actually ever make it to marketing. And so there's been 14 drugs since March of 2023 that have been developed in silico, meaning these digital twins have been used to help develop these pharmaceutical products. So digital twins are something that's going to become more and more common that we'll see because it decreases the cost of clinical trials. At my institution, our revenue cycle management team is using something called Codametrics, which is a robot process automator that helps with transaction evaluation. And so what they've done in 10 months, this model has performed over 400,000 transactions. The data service, the data payment decreased by 40%, which in financial evaluation in terms is pretty significant. And on a per month basis, they're transacting with 17,000 to 18,000 transactions are being done by these models instead of their revenue cycle management team. Their team members aren't being fired, they're actually being upskilled to more complex tasks, which are being left to kind of others to do. At UC Health, we're using ambient documentation called a bridge. Probably many of you have heard of it. It's a device that goes into a clinical visit, listens to your interaction with a patient, and creates documentation from it. We're using large language models to interact with patient messaging on inboxes. and then also using it to summarize charts and EHR information on patients. I'm evaluating it for the NICU space, and to be honest with you, if I were to rate it on a 0 to 10, it's probably functioning at about a 2 to 3 level, and it's definitely not ready for prime time, but it is highly interesting that you could come in Monday morning and have a summary at a high level of your patient over the last 72 hours. Denver Health, another institution that I'm familiar with, is using another ambient documentation system. And what they found in their pilots, that it's reduced note typing by 40%, decreased pajama time, note documentation at home by 13%, and that it improves patient satisfaction. Epic, at their annual user group meeting this past fall, identified that they have over 100 applications of AI in their EHR system. How many of you guys actually use Epic? All right. So Epic's probably in about 65% of the healthcare systems in the United States. So this EHR gorilla is starting to use artificial intelligence in many ways. And it depends on what your institution has decided they're going to turn on or test. But they have over 100 applications, and here's at least a few examples. I'm not going to go over 100 of them, but I've highlighted some of the bigger ones. Evaluate medical necessity criteria, extract cancer staging data from notes using large language models, an AI text assistant, forage and summarize patient messages, predict transplant success and complications, draft denial appeals and clinical summaries, amongst many other things. Even though I said that FDA approval of pediatric devices was slow, it doesn't mean that it isn't occurring in pediatric healthcare centers around the country, because it is being applied. CHLA is using robots to move supplies around their hospital, and these robots have delivered about 2,500 deliveries in a 4-month span, over 132 miles within their institutions, and saved staff about 1,600 hours of time. Children's Nebraska is using it to improve their operational efficiency, improving their surgical volumes by 12%. UPMC is using it to improve otitis media diagnosis. Boston Children's is using it for error detection and alert system. At UCSF, there's something being created called acoustic epidemiology. So you've probably seen it in the adult world, where from voice analysis, there's recognition of patients with developing dementia and Alzheimer's disease. In this case, they're using it for evaluating tuberculosis treatment, because how coughs sound shows improvement over time that these models can recognize. So understanding that TB is being treated. And then there's Children's National, who can use the device, taking a picture of a patient's face and associating it with a genetic syndrome. I knew there'd be some perinatologists and OB folks here. I really took a quick deep dive into obstetrics to see if AI has been applied there, because there's a lot of potential. And my take home from that is that it's not ready for prime time, but there's at least kind of 4 main areas where AI is being evaluated in your space. Fetal monitoring, enhancing ultrasound and MRI image analysis, predicting preterm birth, and for predicting maternal health issues. So I hope that I've convinced you that artificial intelligence is here. How many of you guys knew it was that widespread? All right, so a few. Most of the time when I go there, I see a lot of people's mouths open and say, I can't believe artificial intelligence is this pervasive. So it is. And I want to tell you that artificial intelligence isn't new. What's new is this generative AI. Artificial intelligence has been around since the 1950s. John McCarthy, who was a Stanford professor, was creating a computer science workshop at Dartmouth and came up with the term artificial intelligence. Machine learning, using algorithms to digest data and learn from data over time, has been around since the 1990s. Deep learning, where scientists have created neural networks in computers to act like the human brain, has been around since the 2010s. And generative AI, which creates text, audio, video, and digests that as well, has been around since the 2020s. So really what I wanted to highlight is that artificial intelligence is here. It isn't just one thing. There's multiple tools within artificial intelligence. Natural language processing is a type of artificial intelligence. Computer vision. Machine learning is a subtype of artificial intelligence. Linear logistic regression, which many of us are familiar with, is a type of artificial intelligence. Neural networks, deep learning, convolutional neural networks, which helps with image analysis. And then generative AI. So I think we have to be very specific when we're talking about artificial intelligence, and we can't just use it as a blanket term. It's thrown around a lot of times like magic. If somebody has an issue, oh, we'll use AI for that. We have to stop people from that and making sure that people are really specific about what tool of artificial intelligence they're talking about. I saw a recent survey by the American Medical Association talking about how physicians were more receptive of AI. But if you look at all the survey questions, all they used was the term was AI. So as I've shown you here, there's a lot and different techniques within artificial intelligence, and we have to be much more sophisticated when we're talking about artificial intelligence and thinking about artificial intelligence. So as a general term, artificial intelligence is a branch of computer science, and it uses algorithms and software that end up being able to perform tasks that usually require human intelligence, like learning, problem solving, perception, language understanding, and decision making. Large language models, a type of generative AI, is really the first that will have widespread application in healthcare. Every single one of you could use a large language model today. What it is, it understands text, video, images now, and it can generate text, videos, and images as well. And they're really just prediction machines built on a transformer architecture, built on a huge amount of data. They're trained and understand and have access to all the information on the internet. What large language models have done is they've democratized data. If you have an internet access, you have the ability to use the internet and all of its information as a resource for you if you use these models correctly. So that's what my workshop is going to be. I'm not going to talk much about large language models right now, but for 2 hours this afternoon, if you want to learn how to use large language models in your daily life and quality improvement, I can show you some techniques that will make using these models much easier and much better. So if you're going to join my workshop, make sure that you at least have Gemini, Claude, ChatGPT accounts so we can use them in the workshop later this afternoon. But I think we need to proceed with caution. There's a lot of issues with artificial intelligence in healthcare, and I consider myself a critical optimist. I always think that there's good in things and good in people, but I'm also very critical, and that comes from being a medical director. And really when I started hearing about AI application in healthcare, I really wanted to figure out what are some of the bad things? What are some things that are not going to make AI as applicable as we want it to be? Part of it is data. Garbage in versus garbage out. We've heard this all along. Well, healthcare data is specifically bad for garbage. About 30% of healthcare data is either missing, mislabeled, or incorrect. 70% is usable. Of that 70%, 80% has been largely unusable because it's unstructured data. With some of these new AI models, we're able to actually use some of that unstructured data and get some information from it. We know that EKG interpretation overestimates left ventricular hypertrophy in black athletes compared to white athletes. And why is that? Because these technologies were developed at a time when the patient population looked a lot like me, old white guys. We have to do much better than that and make sure that these models are developed on a diverse population and decrease the amount of bias. And what I showed you for FDA approval makes me very concerned that that bias is only going to be perpetuated. Accountability. Who's going to be accountable when one of these models causes harm to a patient? It will occur. Who's going to be accountable for that? The AI developer? The hospital or healthcare system that purchased the model? The physician or clinician that used it? The patient or family that went out and bought it on their own? Now, these will be decided in the court of law, but I'm pretty much can guarantee you that AI developers are not going to be held accountable. And it's unlikely that hospitals and healthcare systems will. So it's going to fall to clinicians and physicians to be involved in that process and understand that they're going to be held accountable. So that means we have to understand these models a little bit better than we do today. Explainability is a huge issue with a lot of these models. You've heard of the black box probably. Well, some of these models are so sophisticated that even those that develop these models can't explain the output or how their models develop these output. Us clinicians are not going to use models that we can't explain, that we can't verify that they're accurate and correct. And that's where the trustworthiness part comes in. We're not going to trust something that we don't understand and can't verify that the output is actually accurate and correct. So there's a lot of issues, and these are just high-level issues. But this is also another issue with AI right now. There's a huge imbalance between creation and study or use of these models. And really that's because the creation is coming from big tech and data scientists. They think that they have healthcare figured out, that healthcare is pretty simple and can be fixed by running algorithms. I think we all believe that that probably isn't true. But we, on the other side, administrators, educators, clinicians, patients, ethicists, need to be much more involved than we have been up until this point. So another reason that I go around the country and talk to a room filled with people like you all is it's a call to action for you all to get involved. Because AI is here, it's going to expand and amplify. And if we allow it to amplify incorrect output, we're partly to blame. So we have to be involved in at least starting to understand some of these. And this is what I see. So this is a publication from New England Journal of Medicine, not too long ago, probably about a year ago, where the investigators created a model that could act like a primary care nurse and primary care physician. So pretty exciting stuff. There's 30 authors on this paper. 1 is a physician, 29 are data scientists. There's no ethicists, no educators, no patients. 1 doctor, and this doctor hasn't actually practiced medicine in quite some time, I'm told. But this is what I see. We're not as involved as we need to be. And we need to be involved because big tech, insurance, pharma, data scientists, startup companies are focused on profits. They're spending a lot of money on these models and they're expecting revenue generation in return. We are focused on patients and our families and want to make sure care that we provide is better. So we need to be involved in the evaluation and study of these, and it's not occurring. So this is a publication looking at AI application and study in NICUs and in PICUs. They found about 250 studies, about 2/3 that were in the NICU, about 1/3 that were in the PICU. And what this figure shows, it goes from left to right years. And as you see, those dots get bigger as it moves to the right. And what that shows is from 2017 to 2024, there's been a lot more study and investigation of AI in healthcare, in NICU and PICU. The y-axis is kind of where the model development is. And so the very top is the ideation of the model, prototyping the model, testing the model. All the way down to the bottom is where it's actually being used in clinical use. And if you see in the NICU and PICU, it kind of stops at number 4 and 5 going across there. And basically what that means is we're at a stage where most of these are just under model prototype or development, and very few are getting into clinical testing and evaluation. And we need that to change. We need to be making sure that these models are evaluated and tested and that they're safe, effective, ethical, and unbiased. So we really need to change that paradigm and be involved in the evaluation. So AI in healthcare, there's big buckets. Generative AI, and that's what I'll talk about more in my workshop. And I'll give a few examples of machine learning and deep learning here to show you that these models are being deployed, at least in investigation. And I wanted to also highlight that machine learning, there's 2 main types of machine learning, and Dr. New talked about this a little bit yesterday using fruit and vegetables, I think. But I wanted to make sure that you guys understood that machine learning is broken down into 2 main types. Supervised learning and unsupervised learning both have significant power. Supervised learning is we give these models data. So 1,000 retinal images we would give a model. Of those 1,000 images, 900 would be normal, 100 would have retinopathy. Over time, the model would begin to learn and identify what's retinopathy versus normal. And then you could actually then feed the models 1,000 retinal images, and it determines what the retinopathy is from the images. So that's supervised learning. Unsupervised learning probably is maybe some of the more powerful type of learning that these machine learning models can do, because it takes away some of the bias that we have, and it begins to recognize patterns from just data that we give it. So he used an example of intestinal injury and that it's not all necrotizing enterocolitis. Another pathology that we lump together and we shouldn't is bronchopulmonary dysplasia. There's many different phenotypes, genotypes, and subsets of these that we're all lumping together, and I do think that unsupervised learning will help us understand some of these pathologies much better than we do today. So great for pattern recognition from huge data sets. And Dr. New showed this yesterday and found 5 different subtypes of intestinal injury within 183 babies at University of Florida over a period of years, taking about 50 different factors or variables or features from kind of mom's history, perinatal history, and newborn history. This is an example of where we need to take this field so we understand some of our NICU pathologies better. I also wanted to highlight that many people think that AI is going to be just great for us in the developed world and with our high tech. I think that AI may actually have better application in low resource settings. And this is an example. The IROP study group, based kind of out of Oregon Health Sciences and Peter Campbell leading it, has developed models that can help detect and evaluate retinopathy at prematurity from devices that actually can be used. And so their group is studying a lot in India, and they have developed models that are as good as experts at looking at retinas to detect retinopathy. So then increasing access to remote areas using a technology that could be available and then acting like a specialist. So I think there's a lot of capabilities for that. Another example out of Cedars-Sinai, using video analysis of babies in the NICU, looking at 15 different anatomical parts on a baby to see how they're moving over time, and analyzing that video to detect if a baby has cerebral dysfunction, if they have over or under sedation, and how they're maturing over time. And the key findings from the study is that they could actually tell from video analysis which babies had cerebral dysfunction, which ones were over sedated, and what they really recognized, it was the movement of the shoulders and feet, which gave them the most important information. And this was a publication just from a couple months ago. So I think we're really in the precipice of something really exciting where we're going to be able to analyze and evaluate our babies much more so in the future than we are today. And probably a lot of you have heard about the HERO monitor, which was developed at a UVA, and it's really the only randomized controlled trial evaluating machine learning in the NICU to show important patient outcomes. And what they look at is heart rate variability over time, which decreases if a patient is becoming sick with sepsis or so forth. And the model predicts this or identifies this heart rate variability that decreases, which us clinicians at the bedside can't recognize. It alerts the clinicians. They draw blood culture, start antibiotics, and at least at UVA, they've shown to decrease mortality rates by 20% because of using this device in their NICU. And for those of you in the behavioral health setting, there's a model that's out there now that can detect autism spectrum disorder. You take a survey from the parents, you take a survey from the clinicians, and 2 minutes of video of the child, and it identifies autism spectrum disorder with a positive predictive value of 81% and a negative predictive value of about 98%. AI is going to change medical education, and that's a good thing. NYU Grossman and Langoon actually already has a precision medical education track based on artificial intelligence. If you're a medical student in their hospital, you admit a patient with DKA. It reads your H&P and tells you that you missed 4 portions of the H&P that you have to go in and fix. Also says, by the way, on your last in-service training exam, you missed 3 questions on DKA. Here's 5 multiple choice questions to help you relearn about it. And here's 3 references, and you get an email the next morning at 8 a.m. that gives you this information as a medical student. So you have an individualized tutor when you're going to this program. Stanford is integrating AI in its medical education curriculum. There's no That's not surprising. They're really at the forefront of AI in healthcare. They've also developed a medical AI and computer vision track. So if you're in their medical school, you can actually become a computer vision expert. The Mayo Clinic has introduced human skills in the age of AI curriculum, helping physicians and clinicians develop empathy, communication, and ethical decision-making skills alongside AI literacy. NYU Langone is using it to help with their resident selection process, improving their website and social media engagement, reviewing applications using machine learning and natural language processing to identify diamonds in the rough, helping create good interview questions for their applicants, and evaluating their communication skills and being used to detect bias within their application process. So for you clinicians, if you're not going to come to my workshop this afternoon, at least take a picture of this slide. And I think you have all these slides, but these are the tools that you can use every day in your life to actually improve things that you're doing. And for literature review, kind of research review, all of these up here are free except for one. So Research Rabbit, Open Knowledge Maps, Open Evidence is a large language model created on medical publications. Notebook LM, Consensus, Perplexity, all of those are free models available to people that are interested in learning about certain topics in healthcare. Now you have to be careful because not all of the output is correct, but it really is a great, powerful tool to use. My wife, who's a primary care physician, uses Glass Health, and you have to pay for that one, but it helps with differential diagnosis development, and it actually helps her create part of her prognosis notes. So I'm almost wrapping up here, but I hope that in the future, that artificial intelligence is something that we don't talk about any longer as a shiny, new, bright object. And instead, we use it to augment our care, and we leverage the capability to improve, leverage AI to improve our care for our patients and our families. So a day ago, there was a lot of warnings about tornadoes, right? So weather forecasting modeling is a form of artificial intelligence that we've come to trust, and we know weather is somewhat unpredictable, but we knew there was potential for tornadoes here yesterday. 20 years ago, we wouldn't have known that. You probably drove here in a car today, and maybe when you're backing out of your driveway, a car was pulling out and it made you stop and honked at you. Maybe when you were going to change in lanes on the highway today, you had a lane assist warning. That's computer vision, so a form of AI that's in our cars that we somewhat take for granted today. If you've gone through airports, they're now taking pictures of your face and identifying who you are and what plane you're supposed to be on. This is a form of computer vision and artificial intelligence. Netflix tells you what movies you should be watching, and they have an AI algorithm that tells you that. So we're really at the early stages of AI in healthcare, but it's accelerating fast. I read about AI probably 2 to 4 hours every single day, and I can't keep up with the changes that are occurring. I'm a critical optimist. I think that artificial intelligence has a lot of good things, but I'm also very critical and think that there's a lot of issues potentially with it. We have to understand the facts, the myths, the hype that's around it to make sure that it's applied safely, effectively, ethically, and unbiased in our healthcare systems. I'm a co-founder of NeoMind AI, which I invite you all to join. It's a group of neonatologists, data scientists, clinical informaticists that are evaluating AI in our healthcare space. We put on monthly webinars, workshops. We go to many conferences like this around the country, talking with people like you all to try to educate and serve as a resource for you all. We have a webinar that'll be this Thursday, 1 o'clock Mountain Standard Time, from a physician at Children's Nationwide, who will be our Children's National. I always get those two confused. Who'll be talking about triage prediction for ERs in their model. This is our NeoMind AI group. There's 15 co-founders of us from around the country working together. And I want you to know that AI is going to augment our intelligence and make us do better in our care for our patients. It's not going to replace a single one of you. So thanks for your time. I appreciate it. And here's my LinkedIn and email. I'm more than happy to interact with you, email, in person here, through LinkedIn, over the phone, anything like that. So I want to thank you for your time. If you want to come to the large language model, I'll actually show you how to use them. and prompts that you can create that make these much more valuable than doing like a Google search. So thank you very much.